Evaluation of uterine pathologies. Legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only. Content is not intended to substitute for professional legal clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. This section of our course, the students will be able to verbalize the key differences of ultrasounds with fibroids, polyps, and endometriosis. The students will be able to identify the role with POCUS in regards to the initial evaluation of those clinical conditions. They'll be able to talk about significant sonographic features that go along with fibroids, polyps, and endometriosis, including echogenicity and the location within the uterus. Students will be able to explain to be able to distinguish between a polyp, a fibroid, and complex conditions like endometriosis. They'll be able to talk about the limitations and challenges that come along with just doing an initial bedside ultrasound versus a comprehensive advanced imaging that can be done with a more formal ultrasound, an MRI, hysteroscopy, etc. The students will be able to talk about the importance of the skills of the operator in regards to interpreting the point-of-care ultrasounds and the accuracy you will get from assessing those uterine pathologies based on the skill set of the operator. And then the last thing is we'll be talking about the decision-making process in regards to someone you suspect that has a uterine fibroid, polyp, or endometriosis, and then the different possible treatment pathways. So this topic is really important because we talk about it in all the different sections, that point-of-care ultrasounds are so valuable, especially for rural-based clinics, outpatient triage services, because you may not have access to ultrasound, sonography department, real-time decision-making. To be able to grab an ultrasound machine and get real-time diagnosis will reduce the cost, will increase the clinical decision-making time, and allow the patient to be involved actively in the plan, because the clinician can say a lot more to the patient than the sonographer can until the radiologist interprets the results. Ultrasounds are a great non-invasive, low-risk option compared to biopsies, a little more aggressive screenings and testings we can do to determine pathology. It'll improve your workflow. You'll be able to reduce the wait time, improve patient outcomes, be able to get that overall quality with your care improved greatly. You want to be able to be accurate in diagnosing common gynecological conditions. So the ones we're going to focus on in this section are the fibroids, polyps, and the endometriosis. So you want to be able to have early detection of the fibroids and accurately be able to get the size, location, the number, so that even if you're a nurse midwife, nurse practitioner, and you're not the one going to manage long-term the fibroid or discuss removing, you're going to be part of the initial stage to give the most accurate information to that obstetrician, to the person that's going to continue the care. For polyps, especially if they're caught early, you can really help with preventing infertility, abnormal bleeding, and potentially turning into cancer down the road. So you want to be able to accurately identify those things and then pass them on to the right people that can further evaluate what you found on the ultrasound. Endometriosis, being able to get the texture, the morphology to make sure the uterus is really normal versus abnormal will really help, especially those patients that have painful, heavy periods, to determine the endometrial thickness, and the shape and size of the uterus will really help. The other things that are really important, bedside ultrasounds are far more cost effective versus sending them to ultrasound. You've got a lot of extra steps. You've got a whole department you have to manage with staff and a radiologist that has to read it, and it takes a lot of time, versus a clinician being able to do a focused point of care ultrasound is so much better. We can reduce a lot of unnecessary referrals when we can get our information and determine the next steps pretty quickly, and then send them to the next person in the specialty line that needs to be continuing the care based on the results results you find. Helping clinicians to really be able to give strong decision-making answers versus you tell your patient, I don't know, we got to wait till the ultrasound results. You can really determine, here's your uterus, look at the screen with me, here are your ovaries, here's your fallopian tubes, your uterus looks normal, healthy, or there's this suspicious area here that I'm suspecting is a fibroid, and we should get you to the appropriate people to continue management. There's so much we can do, even if there's preventing a complication. You have people that have painful periods, heavy bleeding, potential rupture issue. You want to be able to take care of those interventions before, okay, now you've seen them in the office, they can't get an ultrasound until next week, and they're in so much pain over the weekend, they've got to go to the emergency department. So we can really help to speed up the process of getting information, knowing how to treat them best based on the findings that you are getting. There's many gynecological conditions out there. The ones we're going to focus are the 3 we've already discussed, but I wanted to give you guys just an overall view of an image. I know it's hard in presentations to talk about identifying image interpretation. It's going to be a lot of that conceptual discussion and management and theoretical talk, but it is important, like, to be able to identify where's the uterus, where's the endometrial lining, where is the fundus, the bladder, the cervix. Those things are really important when you're looking at an ultrasound image of the uterus. You can do it abdominally, but most people will do it transvaginally because it's just more accurate. It depends on which way their uterus is tilted, what are their symptoms they're having, those kind of things. But most people will do a transvaginal ultrasound when it comes to gynecological conditions. So the uterine fibroids, we're going to go to the basics of a uterine fibroid is literally a benign tumor, and it can affect the quality of life and affect pregnancies and complications based on the size and is it growing, and keeping a close eye on it in the location. So how does it look on an ultrasound? It's going to appear well circumcised. It's going to be hypoechoic masses, sometimes heterogeneous. They're going to be classified as submucosal, intramural, or subserosal based on where it is in the endometrial lining. And then the ones that tend to cause the most bleeding and infertility issues are the submucosal fibroids. And based on your skill set, you may or may not be able to identify what layer, but you can easily measure the fibroid and give the next person in line that's going to do the further evaluation as much information as your skill set can get you. So the whole point of point-of-care ultrasounds is screening early, identifying that there is a fibroid present, the size, the number, the location, and that could be part of the potential symptoms, or you just caught it by chance because there's something else going on. Keep an eye on the fibroid. Is it changing in size? Are there more? Symptom evaluation, pain, bleeding, are they trying to get pregnant, those kind of things. So the challenges with a bedside ultrasound is you may miss a deeply embedded fibroid, especially in heavier set patients, obese patients. If you're trying to do it abdominally versus transvaginally, depending on where it's located, if it's on the posterior portion, fundal portion of the uterus, and you're doing a transvaginal, it may be a little more difficult to see it based on the location of the fibroid and the uterine placement. So you just, and the skills you have, I mean, if you're rushed and she's in a lot of pain and you don't have the skill set to do image interpretation, you may not know exactly what you're looking at. Endometrial polyps, they're benign growths in the endometrial lining. Many people don't have symptoms, but they can cause abnormal bleeding and infertility issues. And how it looks on an ultrasound, they're going to appear hyperechoic areas within the endometrial lining, best seen when you do a transvaginal ultrasound, which is most of the gynecological conditions. The whole point of a point-of-care ultrasound is you can get rapid decision making, help get some answers, help give some direction to the next person that's going to be managing that condition. You can differentiate between polyps and the fibroids based on the location, and do some further evaluation of the size, the bleeding risk, the management decision of if there's significant polyps present, the obstetrician may be talking to them about a hysteroscopy to do further evaluation. So there are challenges with ultrasounds because if they're small, poorly positioned, hard to visualize, you may not be able to fully assess how significant these polyps are. But the point is you want to do just gross anomalies. As nurse practitioners and midwives and physician's assistants, we're going to be that initial gateway to get them to the obstetrician, the specialist, the person that'll do a more thorough ultrasound, or we may be that initial gateway until they can get into radiology for an ultrasound formal in a couple days. Endomyosis, it's an endometrial tissue invades the myometrium, causing a lot of painful periods, heavy bleeding, and infertility problems. You're going to be noticing on the ultrasound that the myometrium is thicker. It's a little hard sometimes for people to tell the endometrial thickness versus myometrial thickness. It's going to be diffuse thickening throughout the heterogenic echogenicity. There is the Venetian blind sign, the hypoechogenic linear striations in the myometrium will be present. That's more of an advanced skill that not all clinicians can see, but if you're noticing that there's symptoms present and you're having some of these other issues, you could have them definitely just be you're suspecting XYZ and then send them in for a further formal ultrasound. Junctional zone disturbances, indistinct, irregular endometrial, myometrial borders with your ultrasound is another sign to watch for. The whole point, we talked about it over and over again with every single one of these ultrasounds, is you want to differentiate between something else more serious, significant, track progress with a disease, a condition, how the treatments are going, be a first line image if you have a suspected concern, to have a discussion with a patient in the next steps. Any ultrasound based on the skills of the clinician, and if it's early stages of endomyosis, may be hard to detect on the ultrasound, but you can order an additional MRI, which is better for that soft tissue contrast if you're suspecting endomyosis. So there's a lot of challenges and limitations when it comes to GYN point of care ultrasounds. If you aren't skilled, if you've mostly done obstetrical ultrasounds and then all of a sudden you're joining a GYN practice, you need to get some skills and training to know what you're looking for. It's completely different with uterine abnormalities and ovarian abnormalities than you're looking at placental location and newborns, the fetal anatomy, those kind of things. So you want to be able to know the limits of your resolution. Doing transvaginal is better than transabdominal when it goes to gynecological conditions, the quality of the machine you're using, the patient's discomfort. I mean, you may be better off just ordering the MRI if they're having significant pain. When you try to do a transvaginal ultrasound, you always have to look at that risk-benefit analysis. Especially more obese patients, there's just extra tissue you're trying to look through with the probe to get to the organs you're trying to assess. So as an overall conclusion, I just want you guys to know gynecological point of care ultrasounds are just as important as obstetrical ultrasounds. There's a lot of people will come in with pelvic pain, discomforts, issues, and you can get a lot of information pretty quickly with a bedside ultrasound if you have the knowledge and skills to know what you're looking for, and then you can be the gateway to, okay, we need a formal ultrasound, we need to do an MRI, we need to just wait and watch, see if this grows, see if it's there in a week or two after doing XYZ recommendations. I'm going to set you up with the obstetrician in our office, and I'm going to put a report together of what I've found. So there's ways to help speed up processes and get answers and start treatment plans faster based on you being able to just do gross anomalies. I stress to people, you're not a maternal fetal medicine, you're not the expert, but you can notice gross anomalies and significant concerns and put in your notes really well, this was what's visualized, this wasn't visualized, there weren't any gross anomalies, and you're the initial gateway to the more formal ultrasounds.